Hi, I'm Dr. Joseph Lamb. How are you today? It's another one of our Thursday lectures. This is part of our series on women's health. This is the third in the series. You can find the two previous ones right here on Joseph Lamb MD page. And soon enough, we're going to be posting them on YouTube. So share them around. We'd love for people to have the experience that you're having today. We have two more in this series, one on nutritional and botanical support for women's health, and then the final one on self-care and stress management. We are taking next Thursday off, so we're going to be skipping the 29th, but we'll be back on the 6th of May for the fourth in this series. So today, let's talk about bioidentical hormone therapies, or let's talk about the role of hormonal therapies in general. As we talked about in our introduction, going back 2 weeks now, it's sometimes really worthwhile to understand the history of how we've gotten to where we are and how medicine has changed over time. We've talked about the fact that in the past, if you go back to the 1940s, 1950s, 1960s, a lot of women experienced menopause without any sort of intervention. But once we got to the point of being able to understand the structures of hormones, once we got to the point of being able to chemically modify those hormones, so we had new chemical entities, forms of hormones that had never been seen in nature before. Once we got there, we started realizing that we could manipulate the endocrine system. And the initial work certainly centered around oral contraceptives. And it did so because it took synthetic hormones, more potent hormones, to overcome the body's natural rhythms of ovulation and menstruation. Rapidly in that period of time, the recognition came that many of the symptoms that women were experiencing during perimenopause and menopause, whether it be the vasomotor symptoms like hot flashes or night sweats, whether it was some of the mood changes, irritability, depression, anxiety, whether it was the insomnia, whether it was muscle aches and pains or joint aches or pains, whether it was changes in vaginal health, vaginal dryness and atrophy, whether it was changes in the skin, changes in mentation and cognition. All of these suddenly, and even changes in, cholesterol physiology, for example, and women suddenly catching up with men for their cardiovascular risk. In the setting of all of this, it was thought that hormone replacement therapy was the solution. And in a sense, we kind of medicalized the whole process and made menopause, which up until that time had been a normal passage in a woman's life and was dealt with kind of as best as could be, we made it into something that Western medicine viewed as a disease, something that needed to be treated. And by the time I graduated med school in the late 80s, mid 80s, and finished residency in the late 80s and was in practice in the early 90s, it was pretty standard to give all perimenopausal women a low-dose birth control pill, and to give postmenopausal women the combination of conjugated equine estrogens, so horse estrogens collected from the urine of pregnant horses. The estrogens had been metabolized and excreted, and they were collected, and to give synthetic progesterone, or I should say progestin. The class of hormones that includes estradiol and estriol and estrone are called estrogens, and the class of chemical structures that include progesterone are called the progestins. So it was a synthetic progestin that was given as part of that medroxy progesterone or Provera. And the most common conjugated equine estrogen was Premarin. And they were given to women because we thought we were helping with bone health. We thought we were helping with cardiovascular health. And we certainly seemed to be able to ameliorate symptoms. The downside, however, was that there were increased risks for ovarian cancer and there were increased risks for breast cancer. And so the Women's Health Initiative was undertaken. It was a large study, and the purpose behind doing it was to really answer the question, are we doing the right thing for women? And that study enrolled nearly 100,000 women, and it looked at lots of questions. Dietary questions were asked, disease prevalence questions were asked. It wasn't just a study of hormonal therapies, but that was the major focus. And women were enrolled and placed on either Premarin alone if they did not have a uterus. And if they did have a uterus, they got the combination of Premarin and Provera. And so surprisingly, the study was stopped early. And it was a surprise because we thought we had been doing the right thing for women. And then suddenly the study came out and it was stopped early because the safety committee threw the yellow flag and said, hey, we may actually be hurting more women than we're helping. And what had happened was they had failed to see the benefit in terms of the reduction in cardiovascular disease, which had been seen in kind of retrospective trials, meaning trials looking back at data that had already been collected for other reasons, kind of past experiences, and that had suggested that estrogen prevented coronary artery disease and prevented cardiovascular events like heart attack, stroke, sudden death. And suddenly, in the Women's Health Initiative, a prospective study where women are randomized to one group or the other and you watch what happens to them going forward, we didn't see that cardiovascular reduction. And indeed, we saw some cardiovascular complications like blood clots and pulmonary emboli and thrombotic strokes taking place. And so suddenly, with this increased risk and no real reduction from the cardiovascular point of view, and with the movement towards using selective serotonin reuptake inhibitors or antidepressants for some of the vasomotor and some of the cognitive and emotional symptoms related to menopause, and given the commercialization of the bisphosphonates, which were the drugs used for preventing osteoporosis, which have some side effects of their own, but and may actually be good at creating brittle bone and giving bone density changes on DEXA scans without necessarily making healthier bone. But despite that, the view was that they were effective drugs, that there were effective choices, and that when you threw in the cardiovascular deaths from stroke and pulmonary emboli and added that to the cancer risk, that we were doing women a disservice. So suddenly, beginning in 2002, 2003, a whole generation of women would not receive hormonal replacement therapy. Well, it was a huge study, a huge amount of data. And when safety committees look at this data, they're not doing a deep dive. They're not asking complicated questions. They're just saying, Do we see safety signals? And so when we did a deep dive, we found that perhaps part of the outcome was related to the fact that maybe the study design wasn't ideal. And in retrospect, two decisions which up front looked like good ones contributed to the fact that it wasn't such a great study. One was they wanted women who were naive to hormone replacement therapy. So they didn't want to be enrolling a group of women who had already been on low-dose oral contraceptive pills or had received some sort of other therapy or had already received a different kind of therapy for hormonal therapy. They wanted people who were new to those therapies. And the other piece was they wanted women who were continuing to have vasomotor symptoms. So they could actually test the premise of whether or not this reduced the presence of hot flashes and night sweats and the vasomotor symptoms. Was it efficacious, not just what the risks were? And two things happened as a consequence. One, a lot of the women who were recruited were older than immediately menopausal, because menopause is described as that 1 year period after the last menses. And, during that 12 months, that's menopause. And then after, it's postmenopause. And a lot of the women who ended up being enrolled were several years out and continuing to have symptoms. And interestingly enough, it seems like people with poor lifestyle choices and people not in the best of health are the ones who have the hardest time tolerating the change of menopause into postmenopause and remain symptomatic. And so that was probably a sicker group. And there was probably a bias as well in the group who had never been prescribed hormones now getting them, because they were probably a higher risk group. And on average, women were about 5 years out by the time they started taking hormonal therapies. And when the data was eventually looked at closely, there was some suggestion that the Premarin alone group seemed to be doing better than the Premarin Provera group, number one. And number two, there was a real suggestion that in the group who were closer to the time of their menopause, that there seemed to be a reduction in coronary artery disease. There was a trend towards it in that group. And the belief was that if the study had run for as long as it was intended to run for, that we would have shown a benefit there, but it was stopped. So it took a decade. In many circles, it took a decade to get around to the fact that perhaps hormonal therapies were still indicated for women. And the question then became, which therapies? And I think that's where the functional medicine model really fits in well. The loss of hormones during perimenopause, menopause, and postmenopause is not an isolated occurrence going on in a woman's body. It is a pattern of changes that go on, just like, is there changing thyroid hormone levels? Are there changing insulin levels? Is obesity developing? Are we developing other risks? Do we exercise? What do we eat? How is this all done? So it can't be, looked at as all women are exactly the same and everybody gets the same pill like we were doing with Prempro, the combination of Premarin and Provera. Instead, it becomes one of, what are the health goals? How symptomatic is this woman? What is it that we want for down the road? And given that it is that piece and it is what we want for down the road, it becomes this opportunity to say, how long are we going to treat? Is it just to get through particularly uncomfortable symptoms? Is it to reduce cardiovascular risk? Because, the evidence would support that started during the immediate perimenopausal kind of menopausal time, bioidentical hormone therapy does seem to reduce cardiovascular risk. It is probably more effective than the bisphosphonates for promoting good bone health. And it is, as opposed to giving a selective serotonin reuptake inhibitor, it is giving back to a woman a hormone that she's lost. The question is which hormones, how much, how to measure them, and all of those components. So let's talk for a moment about which hormones, are available. And backing up for just a moment, I think it is crucial before you make the decisions about which hormones to take in this setting that you assess the risk, you assess cardiovascular risk, you assess the risks for blood clotting and the risk for various cancers. You create a lifestyle, a food plan, exercise, cognitive behavioral techniques, mind, body, spirit techniques. You create a program that gets a woman on a wellness trajectory, because wellness isn't a destination. It's a journey to get there. And you start that program and then you see where the hormones fit in. You can still order conjugated equine estrogens as a prescription. You can still order the synthetic progestins as a prescription. But many practitioners, particularly in the functional medicine and integrative medicine world, like using bioidentical hormones. So where did this term bioidentical come from? Well, it was a term that was felt to be necessary to describe what these hormones are. Typically we think about things being natural and synthetic, right? And we think about hormones being, something that is comes from nature and you can just give to someone. So if you get insulin or thyroid hormone from a pig, for example, then that is a natural source. Or if you could find one of these compounds in a plant, and there are botanical estrogens, there are phytoestrogens which can be given. And we'll be talking more about those at our next lecture. But, if you find it in nature, it's considered natural. Like if we could get estrogens from human beings, for example, it would be natural. But when you have to do something, when they're modified in some ways during that process, like for example, if it's a horse source of estradiol, but it's conjugated and metabolized so it can be excreted, that is no longer, exactly the hormone that it was. And, unfortunately, we don't have a great plant source for hormones. We don't have any plant that makes estradiol. We have chemical structures very similar, ropantocin, ropantogin, which is in estravera, resveratrol, for example, even, the soy genistein and datastine, red clover. We have all these similar type kudzu. We have all these similar plants. The hops compound, for example, 8-perenylnerinogen, all of these phytoestrogens, but they don't have the structure of estradiol. And what we can do is in a test tube, or larger than a test tube, in a vat, we can take these raw materials and modify them and extract them, and we can end up with estradiol. which would be identical to what's in a woman's body and a man's body because men have estradiol within them. But when you do that, unfortunately, it's no longer natural. It's been synthesized. It's now man-made. And so people wanted to make the distinction between hormones that came from a natural source, like we got it from a horse, but it came through the urine, so it doesn't have the same structures necessarily, to, okay, we are, getting it synthesized, but it's identical. So that's where the word bioidentical came from. And there is evidence to suggest that bioidentical hormones, whether it's the estradiol or the estriol or the estrone, are preferred over the other estrogens, like the conjugated equine estrogens, just like there's evidence that suggests that progesterone, natural micronized progesterone, which can be sourced from plants like yams, for example, and chemically modified and turned into the exact structure of our own progesterone. When you look at it, there's evidence to suggest that they are better. Where you get into an issue is that for a number of years, there weren't good sources of pharmaceutical grade hormones that were readily available to patients, to women to use. We now have both estradiol and in oral forms, and we have estradiol patches. We have a natural micronized progesterone. You can buy these from pharmaceutical companies. The pharmacist in your chain drugstore can take it, out of the box or out of the bottle, put it in your little bottle, your little box, hand it to you, and you're on your way. But what's missing there is picking the delivery system, whether it's going to be on the skin or whether it's going to be sublingual or intravaginal or, oral, whatever the form is going to be, of getting the hormones, that the compounding pharmacist gains that ability to make a unique formulation and a unique dose for you. I'm frequently faced by the fact that, when I use the, 100 milligram or 200 milligram natural micronized progesterone, the pharmaceutical prescription that I can write. But a lot of women need a little bit less. And it becomes pretty apparent, what levels you need when you measure some blood work. And we'll talk about that in just a moment. Or salivary or urine. But measuring levels help you know what you want to achieve and help you know if you're giving the ultimate amount that's worthwhile, if it's being absorbed in the gut, overly metabolized in the liver, and the such like. When you give progesterone, for example, first pass through the liver makes metabolites that are neuroactive. They work on the brain. That's why we give progesterone at night if we're giving it orally. And sometimes we take advantage of that because those compounds are relaxing and sedating. If we don't want those effects, then we give topical progesterone, and we can give it at a lower dose because most of it's not metabolized in the liver when you give it through the peripheral circulation by putting it on the skin. So bioidentical is, in my mind, the preferred source. Compounding has been a big issue because there are a lot of people who feel that compounding pharmacies make mistakes. And there are some compounding pharmacies that don't do a wonderful job. But, we're really fortunate here in Gig Harbor. We've just had a new pharmacy open, Harbor Health, and a pharmacy and apothecary right down on Judson Street in Gig Harbor, and they are one of the highest level of certifications for compounding pharmacies in the whole state of Washington. So it really is exciting that they're there. So, the advantage being when you start compounding that you can give like estriol and estrone, you can also give some DHEA, you can give some testosterone, you can put it all together in the same cream, or you can pick and choose. I have women who I'm using pharmaceutical grade estradiol patches, natural progesterone as an oral tablet from the pharmaceutical company. And then I have a compounding pharmacist making like a DHEA testosterone cream, for example. So you pick and you choose, you look for the benefits. I do think it's really important to measure levels. Particularly when you've reached maintenance dose, you want to know that you're within your target. You don't want to be giving too much. And you certainly, if symptoms are still present and you're giving too little, then you have an opportunity to say, okay, I'm going to increase the dose. Not so important to get levels at baseline, particularly if a woman's menopausal, because you really know that the FSH is going to be elevated. You really know that progesterone and estradiol are generally low. Where levels become more helpful is in premenopause and perimenopause as you try to adjust how much you need. And the reason for, not just giving whopping doses, even though there are probably some upsides in terms of, keeping breasts plump and, maybe preserving skin integrity. Certainly there's a whole school of thought and kind of the some anti-aging fields of like restoring women to hormone levels that they had in their 20s. But that's not necessary for wellness. That may have cosmetic benefits, and it may have some anti-aging benefits, but it increases the risk for the downsides. And so that's why it becomes important to measure levels, find the right dose, find what you need to find to give back to the woman the functions that she wants to have. Saliva reflects the amount of hormone that makes it into the tissue, the salivary gland. So it's thought to represent tissue levels throughout the body. Blood is how much is circulating, and urine is frequently how much is metabolized. The nice thing to look at, and because hormones are a dance, you can also use saliva to look at cortisol levels. You can even use saliva to look at salivary levels of, thyroid hormone. And it becomes an opportunity, blood, saliva, to look at these components and make decisions about how you promote good health. So at the end of the day, it's an individual decision for every woman. It should be coupled with a lifestyle program, coupled with a disease assessment, risk assessment for other things that may be going on. And the therapy has to be tailored to meeting a woman's needs. It's what we do here at the Personalized Lifestyle Medicine Center by Metagenics in Gig Harbor, 253-853-7233. If you'd like to come and visit and have a personal conversation about this. As a kind of a side note, as I said, we won't be here next Thursday, but 2 Thursdays from now, we'll pick up our series. And this Saturday morning, Michael Stone, Susan Buell, Courtney Suter, and I are going to do 90 minutes of recreation and visioning. And I hope you'll join us for that experience. All right. Thank you and have a great day. I wish you well.